Good afternoon and good morning and good evening to everybody who's joining us from around the world. And at the risk of disappointing my high school Spanish teacher, I think I should probably say buenos dias, because we are pegging this webinar and a series that I'll describe in just a minute to a conference that is coming to Lima, Peru next year, next October 2024. And as many of you know, our original intention was to be there this year, but we are not. But I did want to welcome everyone, no matter where you are, no matter what language you speak, to this webinar, the first of three in a series as part of the HIV Research for Prevention, HIVR4P conference symposium. As many of you may know, for many years, now more than 20, there had been an annual HIV vaccine conference and a biennial microbicide conference. And in 2014, a number of groups came together to bring the streams of work together into what has become HIVR4P. And the first conference was in 2014, and it has grown not only to discuss HIV vaccines and microbicides, but PrEP, increasingly conversations about multi-purpose technologies, but also conversations about implementation science and about policy and advocacy, but community engagement and research. And those conferences have happened every 2 years, more or less. Of course, like many things, it was disrupted in the midst of COVID in 2020, and the conference moved all virtually in 2021. We're excited at the International AIDS Society to bring the conference back to in-person and back into the even years. It'll be in 2024, opposite the larger AIDS conference that happens the middle of next year in Munich, and I encourage everyone to be aware of AIDS 2024. But R4P is really an opportunity to go deep into important HIV prevention conversations. But given that we last met in 2021 under the R4P banner, the International AIDS Society, the Governing Council, and the HIV R4P Organizing Committee felt it was really important to bring us together as a community, virtually at least, for 3 webinars, this being the first focused on long-acting pre-exposure prophylaxis, injectable PrEP, as we often talk about it. And there'll be 2 more, and we'll give you details at the end of the call, but they're on the IIS website where you registered, one focused on HIV vaccines, and the third focused on broadly neutralizing antibodies. I think it is safe to say that the HIV prevention research world has never had more opportunity to advance the science, but more challenges to conduct that science in the current environment, both the HIV environment, but also the political, economic, and social environments that make our work challenging, which is why we still need this research and development to continue. And I'm delighted to welcome all of you here to this first call. As I said, we're going to be focusing on injectable PrEP, which over the last couple of years has shown in 2 large efficacy trials that you'll hear about to be an additional safe and effective product. Along with the dapivirine vaginal ring and oral PrEP, we now have 3 antiretrovirals that are available in different delivery systems for PrEP. And just saying that alone in 2023 is pretty remarkable, and something I think all of us working in this field need to celebrate, but also need to recognize the hard work ahead. And I'm delighted to have 2 fabulous friends and colleagues who will provide really important presentations over the next 25 minutes or so to help frame a conversation that we hope to have with all of you. We have a very large audience joining, and we're delighted for that. You hopefully know on your interface to be able to put questions in, and I will hopefully shortly after the bottom of the hour, no matter where you are, we will get to those questions and answers. And rest assured that we will be keeping these conversations going throughout the next year, and we'll be returning to many of those in Peru next October at the in-person Research for Prevention conference. But it is really an amazing opportunity to talk about the science and about the policy and advocacy issues related to what is now one of our some of our newest interventions. We have 2 phenomenal presenters. The first is Beatriz Grinsztejn, who many of you will know, and I don't even know where to begin with her introduction. She's, of course, been a leading researcher on pretty much anything and everything related to HIV, based in Brazil, but has been part of the AIDS clinical trial group funded by the NIH, the ACTG, part of the HIV vaccine trials network, the HVTN, the prevention trials network, the PTN, and like many investigators, really at the forefront of adapting the HIV research endeavor for COVID vaccine and antibody research during the height of the pandemic. For purposes here also, it's important to note that along with a number of colleagues led the HPTN 083 trial, the first of the two studies that showed that injectable cabotegravir was indeed safe and effective. But really importantly, Beatriz has also been at the forefront of implementation science, first pioneering oral PrEP in activities in Brazil and in the region, but also now leading in projects you'll hear about in Brazil around introducing new technologies through UNITAID-funded implementation science. So I can't think of a better person to talk about both the research and the flow into implementation, particularly focused on cis and trans women and men who have sex with men, the focus of the HPTN 083 study. After Beatriz presents, we will then shift from Brazil to Zimbabwe, because this is indeed a global conversation. And I'm delighted to welcome another dear friend, Imelda Mahaka, who also wears many hats, but is the executive director of the Pangaea Zimbabwe AIDS Trust, or PZAT, which is one of the leading organizations working anywhere in the world, not just in Zimbabwe, at the interface of science, policy, and advocacy. And PZAT is involved in a number of activities, both PEPFAR-funded implementation activities, working closely with the Ministry of Health in Zimbabwe, as well as in the region. She also leads a really robust portfolio of projects focused on implementation science, including her involvement in a USAID and PEPFAR-funded project called Mosaic, one of the largest projects looking at introducing both the dapivirine vaginal ring and injectable cabotegravir. She's also a remarkable advocate and partner, and leads a number of advocacy engagements. And I'm delighted as the director of AVAC to have PZAT as a partner in two projects that we get to collaborate on, actually three, in addition to Mosaic, where we both partner. We are part of the CASPR Coalition, a coalition to accelerate and support prevention research, where PZAT plays a critical role, as well as the COMPASS Coalition, driving some of the most innovative advocacy focused on implementation. So I can't think of a better person to present on where we are with new product introduction and the idea of choice than Imelda. So those are the two people you will hear from. And it's my great pleasure first to turn to Beatriz. We will then go straight to Imelda, but I really want to encourage people to include your questions as you hear things presented, so we can get back to those in the conversation. So without further ado, Beatriz, welcome, and the table or the platform or the screen is yours.
Thank you so much, Mitchell, for the kind introduction. It's great to be here with you. Good morning, afternoon, or evening, depending on where you are. Just to complement Mitchell's introduction, I'm also the president-elect for the IAS. And it's a great pleasure and very important for the society to have this webinar series in preparation to HIVR4P in Lima in 2024. So, despite the major advances in treatment and prevention, the HIV pandemic continues to pose a major global public health challenge. By the end of 2022, about 39 million people were living with HIV worldwide, with estimated 630,000 deaths, and importantly, 1.3 million new infections in that year. By the second quarter of 2023, over 4.9 million people had initiated oral PrEP worldwide, and despite the evidence of impact on incidence in some settings and populations, we are still quite far from the global goal. As such, many people who could benefit from PrEP are still left behind. So, although PrEP is not meant to be a lifelong requirement, individuals need to both initiate PrEP and remain on PrEP during periods at risk of HIV, and when high adherence is needed, what may be quite challenging to achieve, especially among the most vulnerable. As such, daily PrEP or even other forms of oral PrEP use on demand, for example, is not feasible for everyone. So long-acting PrEP agents have the potential to address some of these concerns by providing consistent protection through infrequent, discrete administration. In this presentation, we will focus on injectable CAB-LA, a potent stem transfer integrase inhibitor that was evaluated for HIV prevention among different populations. Next one, please. Two large, as Mitchell said, two large randomized controlled trials have demonstrated the effectiveness of CAB-LA when compared to oral TDF-FTC PrEP, HPTN-083 and 084. HPTN-083 was a double-blind, double-dummy randomized controlled trial which assessed the effectiveness of CAB-LA for PrEP compared to oral TDF-FTC among over 4,500 participants in the US, Brazil, Peru, Argentina, South Africa, Vietnam, and Thailand, and showed a 66% reduction in new infections in the CAB arm when compared to active TDF-FTC. With a similar design, HPTN-084 observed an impressive 89% reduction in new infections in the CAB-LA arm compared to TDF-FTC among cisgender women in Botswana, Kenya, Malawi, South Africa, Swaziland, Uganda, and Zimbabwe. Both studies are ongoing in an open label extension phase. Next one, please. So these results led to the FDA approval of CAB-LA for HIV prevention in December 21. And from then on, other agencies also approved cabotegravir-LA for PrEP. Next one. So just to remind people of the efficacy analysis that we have thus far. Next one, please. So as you can see, this is the aggregate of the blinded and 1 year unblinded data from HPTN-083. So you can see, as I said before, an amazing reduction of 66% among in incident HIV in the CAB participants compared to TDF-FTC. Next one, please. And in this slide, you can see the data from HPTN-084 in the same period. And similarly, HPTN-084 observed very impressive reductions in HIV incidence. So what you can see there is that 89% fewer infections in the CAB group, showing the superiority of CAB-LA over TDF-FTC in preventing HIV among cis women. Next one. When examining specific subgroups, the magnitude and direction of the effectiveness of CAB-LA in HPTN-083 and also in 084 was preserved among populations who have historically experienced greater adherence challenges with TDF-FTC PrEP, including among the youth, transgender women, cisgender women, and including those using different modalities of contraception and Black participants, for example. Next one. So now moving into the safety aspects, please, next one. The injection site reactions were the most frequent adverse events in HPTN-083. As you can see in this slide, about 80% of 083 trial participants in the CAB arm referred an injection site reaction, mostly of them mild to moderate. You can observe that the reporting of those injection site reactions went down over time, and only 2% of people actually discontinued injections due to injection site reaction. Next one, please. And as you can see here, in HPTN-084, there was much less injection site reactions, and 21% participants had any injection site reactions, and no discontinuations happened in 084. Next one, please. So data are still being collected on the safety of CAB during pregnancy and breastfeeding, but data so far does not suggest that there are any safety concerns. Next one. And it's important for you to get that there are now 465 pregnancies with already 232 live births in HPTN 084. And because in the open label in extension, there were not requirements for long-acting contraception use. And so we had prevalent and incident infections, pregnancies in HPTN 084. And there is a sub-study of CAB-LA and pregnancy ongoing. Next one. So now we will talk about potential failures and the HIV testing challenges. Thank you. We will, as a long-acting drug, CAB-LA can make diagnosis challenging in HIV if HIV infection is not diagnosed before CAB initiation, as it suppresses viral replication, delaying antibody production. Failure to diagnose HIV infection can lead to continued CAB administration and even continued CAB injections. So as you can see in this slide, these are the different time points of HIV infections that were diagnosed during HPTN 083. You can see the group A cases, HIV acquired at enrollment, the B cases, HIV acquired without recent CAB exposure, the BR cases, HIV acquired more than 6 months after the last CAB injections, and an injection was given at the time of the first positive visit, and group C cases, HIV acquired during lead-in, and group D cases, HIV acquired in the setting of on-time CAB injections. And also group DX cases with HIV acquired while on CAB, but with at least one 10-week delayed injection. And we will now give some details. Keep the same slide, please. So talking specifically among group A, the lessons learned are if we don't diagnose HIV before PrEP agents start, during acute or eclipse phase infection, that is very early infection, CAB can make it challenging to diagnose these HIV infections later. And failure to diagnose HIV infection can lead to continued CAB administration and even continued injections and emerging integrase resistance, as you can see in this slide. If you don't, now moving into group C, if you don't take CAB and people who want injectable PrEP have challenges in using oral PrEP. And so we had the 5 weeks that we used oral CAB before the injections, and some infections, of course, occurred during that time. So if you don't take CAB, oral CAB, in this case, it doesn't prevent HIV infection. If CAB delays new incident detection by delaying testing, CAB injections can again inadvertently be given. And as with case A cases, also with high CAB levels that can lead to CAB and other integrase resistance. Group D, and I think that this is important for you to pay attention, these are infections that were very rare, but although rare, they occurred in people who were taking the injections properly within the windows. And so in these cases that were breakthrough infections.
We pretty late this morning, so I'm going to allow us to.
Resistance
about 10 minutes, okay?
Can be avoided by earlier detection. Where delays occur,
what is it that
when delays occur, CAB levels can drop, losing protection, but not leading to integrase resistance today. And finally, talking about group B, that were the injections, that the infections that happen in the tail phase in people who were not taking, who left the study, were not taking CAB injections anymore. And so these, there were infections that were acquired, of course, although we were doing TDF-FTC PrEP for these individuals during the first 48 weeks of follow-up. And it happened that these people also didn't take oral PrEP. And so these infections occurred during the tail, but however, these infections didn't bring any integrase resistance so far, but it doesn't rule out that this can happen, and we need more data. Next one, please. Next one, yeah. So as you can see in this graphic, during acute primary HIV infection, we have very high HIV RNA levels. It's the first biomarker to increase and to be detected, reaching high levels in the first days, and then followed by the increase in the antibodies. Next one. Differently, this is a graphic showing how acute HIV infections occur and in a completely different fashion that the regular acute infections we see in the clinical practice. So as you can see, antibodies take a long time to be during, when you have CAB in the system, you don't develop neither high levels of RNA, HIV RNA, nor HIV antibodies in the timing expected. So once the levels of CAB-LA decrease in the system, you have an increase in HIV antibodies, but this can take a long time. Next one. And so the symptoms that we are using, signs and symptoms we are using to see with acute HIV infections are not found in HIV infections that happen under CAB-LA use. Next one. So, and just mentioning about this resistance and the fear that there is in the field about the emergence of the resistance, we will just discuss in a minute the elegant mathematical model of rapid scale-up of PrEP that was done by, developed by Andrew Phillip in Sub-Saharan, using the scenario of Sub-Saharan Africa. And if there was a complete switch to CAB-LA in this region. And it suggested that CAB-LA would result in a 27% reduction in HIV infection and reduction in the numbers of people living with HIV, but associated with an increase in the absolute number of people living with integrase resistance virus. Despite this finding, importantly, implementation of CAB-LA PrEP would lead to a decrease in HIV-related mortality in the region. Next one. Now moving a bit to clinical use and implementation. Next one. Importantly, expanding HIV prevention options need to be done while expanding PrEP coverage, ensuring that the introduction of a new PrEP modality increases access and reduces disparities in PrEP uptake, rather than simply providing alternatives for individuals already engaged in PrEP and doing well. So the rapid development of implementation science to guide the large-scale adoption of long-acting injectable PrEP will be vitally important to understand the outstanding issues and implementation approaches for populations who urgently need effective prevention choices. Next one. And so in this slide, it's a busy slide, you can see the list of the current implementation projects of CAB-LA that are planned for the different regions, predominantly in Africa. So these studies are planned for the different regions and also for different populations. For instance, in Africa, they focus mainly on cisgender women, and in the two studies in South America, focus on MSM, young MSM and transgender women. Next one, please. So in this map, you can see in dark blue the countries where CAB-LA is already approved for PrEP, and in light blue, those where CAB-LA was filled for registration, and in red, the countries where there are planned submission plans to the national regulatory agencies. There is still a lot to go, but it is a promising progress, but remembering there is still a lot to go. Next one. And very importantly, in this map shows in blue the 90 countries listed in the Medicine Patent Pool VIV CAB-LA for PrEP voluntary license. So on top of this, sales up outside the licensed licensed territories are allowed in the countries where no patents were filed, including the countries shown in orange. So although this announcement represents a potential game-changing moment in HIV prevention, generics won't reach the market for a few years. We expect that it's earlier than planned. Until then, affordable bridging prices must be agreed upon so that this product can actually reach people immediately. Also, the license needs to evolve to encompass technology transfer to shorten the time for generic availability as fast as possible. With the current direct and indirect and indirect territorial coverage included in this licensing deal, there are still far too many people left behind, including those who stand to benefit the most from this scientific advancement. Next one. In conclusion, long-acting cabotegravir is highly effective for prevention of HIV in MSM, transgender women, cisgender women, and the various subgroups on these populations. Tenofovir-based PrEP is as well very effective when properly used. CAB is safe, generally well tolerated, and data does not suggest there are safety concerns for use during pregnancy or breastfeeding. The washout period after last CAB injection is longer in individuals born female compared to individuals born male, favoring CAB-LA protection in cisgender women. RNA testing can find CAB breakthrough infections earlier and often before resistance, but at high cost, and may not be feasible in many of our settings. Next one. And just to finalize, it's never enough to reiterate that inequalities are a major driver of the HIV epidemic, which continues to disproportionately burden vulnerable populations despite the availability of effective preventive and therapeutic interventions. Stigma and discrimination remain as significant roadblocks. The interplay of different forms of discrimination goes beyond homophobia and transphobia to include race, ethnicity, and social class. All these forms of discrimination, coupled with HIV-related stigma, significantly hinder access to the health services. And the most vulnerable populations struggling with poverty and social inequalities are the ones that suffer the most from HIV. So hopefully long-acting PrEP will not deepen the already profound inequalities, and on the contrary, may it be a step forward in our efforts against inequalities. Thank you very much for your attention.
Beatriz, that was brilliant, and all of it was brilliant. I apologize for not having, of course, introduced you as the president-elect of IAS, but you gave great reason to why you are, and that was just beautifully done. And your last slide was the perfect transition into our next presentation. And I think we all know this, even though the R4P webinars are on injectable PrEP, vaccines, and antibodies, we know that no intervention is purely a biomedical one. And if you don't address health equity and health systems and individual behaviors, no biomedical product gets used. And that's why civil society engagement throughout this is so important. And that's why I'm especially happy to turn it over to you, Imelda, to talk about a civil society perspective on implementation and scaling up. Oh, and before you start, let me just say, please, we have questions coming in. I want to encourage people not only to put in questions, but also you're allowed to, if you click on the thumbs up in the interface, you actually can upvote a question. So it's not just left to my own discretion. So feel free to not only put in your own questions, but vote on and give thumbs up to questions that you like and want to get asked. And with that, I'm so sorry, Imelda, let me turn it over to you.
Thank you, Mitchell. So I thought it was important to start by highlighting the role of civil society in the response. So civil society has been part of the HIV/AIDS response from the very beginning of the epidemic, using some of the traditional roles like advocacy, activism, government watchdog, and community caretaker, which have been critical to the response. We have also played a huge role in the provision of HIV prevention and treatment services and helping to ensure continuity of care. Now, our role is more important than ever as we focus on epidemic control and ending AIDS by 2030. Focusing on HIV prevention. Where are we now? Now, the burden of HIV in sub-Saharan Africa remains unacceptably high and disproportionately affects girls and women. So the introduction of oral HIV pre-exposure prophylaxis a decade ago revolutionized HIV prevention. However, its effectiveness is dependent on user adherence. So long-acting formulations for PrEP, such as dapivirine vaginal ring and injectable long-acting cabotegravir, known as CABLA, are critical additions to the HIV prevention toolkit and important for populations such as adolescent girls and young women and other key populations who remain at significant risk of HIV acquisition. So to date, nearly 4.9 million people have initiated PrEP globally, and I think Beatriz alluded to that, with strong increases in 2022, as you'll see in the next slide. However, we missed the UN targets of reaching 3 million users by 2020, and this figure of 4.9 million is thought to represent only 10% of those who are at risk and could benefit from PrEP. Looking at country trends in oral PrEP uptake, again, more than a decade after its approval, oral PrEP access is still concentrated in a relatively small number of countries, and PrEP distribution within countries is not equal, resulting in a significant unmet need for PrEP. Granted, we have seen a steady increase in uptake more recently, but what does this really mean? I think we're all familiar with this narrative. While we have seen increased uptake, PrEP continuation rates tend to decline significantly by 3 months after initiation. And this was seen in studies and similarly in programming. Which is why choice matters. Communities together with civil society have been advocating for choice for some time now. Choice is critical for meeting the diverse needs and preferences of those who may be at risk of acquiring HIV. Learning from contraception, data from the WHO systematic review shows that increased choice is associated with increased persistence, better health outcomes, and an increase in contraceptive prevalence for each additional method. We need more HIV prevention options for people to choose from, and we'll likely see an increase in access, uptake, and persistence learning from contraception. Recently, civil society, through the African Women's Accountability Board, along with Winnie Banyima from UNAIDS, launched the HIV Prevention Choice Manifesto for Women and Girls, a landmark moment for civil society. I also take this moment to also call out a few groups that have been pushing for choice in the civil society community, like the Global Key Pop Advisory Group, that is similarly elevating advocacy for accelerating introduction of new options. The Civil Society Caucus in the Long-Acting PrEP Coalition, which includes members from the Women's Accountability Board, AfroCAB, and many other grassroots groups. For choice to become a reality, it requires a multi-sectoral approach, pulling in your policymakers, your researchers, developers, donors, governments, communities, and implementers to make the mix available, accessible, and affordable. Speaking of choice, there has been excitement with the introduction of 2 new PrEP products. We just heard Beatriz talk about injectable cap and then the dapivirine ring. So as we prepare for these new products, we have quite a number of planned CAB and ring implementation studies, with the majority of things being conducted in Africa. Obviously, we see this as a plus, as sub-Saharan Africa accounted for more than 50% of the 1.3 million new infections in 2022, and 63% of these new infections were among women and girls. Within the studies I just highlighted in the previous slide, it's good to note that most populations are represented within these studies. I'm especially excited that the current studies have included pregnant and lactating people or populations, adolescent girls and young women, trans women, populations that were often excluded earlier in clinical trials. Of course, there's a gap in people who use drugs and prisoners. As civil society, inclusivity is critical if you are to leave no one behind. So we implore researchers to include these populations. Just looking at injectable CAB introduction, currently we have 8 studies in 6 countries, and majority of those are in Africa under the Catalyst study within the Mosaic project funded by USAID. And we have 20 plus studies in the pipeline. So that's really exciting. Over and above the studies that are introducing CAB, we also have 5 countries that are receiving CAB through PEPFAR allocations with other countries on the waiting list. So it's important to notice that Zimbabwe is unique in that it has both the implementation study and the Catalyst, as well as PEPFAR support. It'll be interesting to see the synergies and how they can learn from each other. Now, with all the excitement of CAB-LA and WVRing, there are significant opportunities, challenges, considerations, and emerging lessons. So we have 3 products that we're looking at the moment. There's oral PrEP, there's dapivirine ring, and injectable CAB. And each product has different issues, which I'm sure most of you are familiar with. And there are issues irrespective of product, which include health systems, structural issues, etc. Now, I have the privilege of working in advocacy, programming, and implementation research. And I realize it's not just what the advocates or the end users want. It's not just what the researchers or governments or PEPFAR or donors want. The question is, how do you bring all this together to ensure sustained access to those that need these products the most? So this graphic shows the whole cycle from when clinical research is conducted to gather evidence on products, to normative guidance where countries largely rely on WHO to adopt and adapt normative guidance. A huge piece that countries also push for is implementation science or demo projects to guide country-level policies, which then leads to rollout and scale-up of products. As civil society, we are involved in the continuous cycle, but we do have concerns in terms of how some of the processes have been happening. So we have evidence through clinical trials that demonstrate that these products work, but there are challenges in the long delays between generation of evidence to finalization of normative guidance. We also have delays between the normative guidance and country adoption to roll out and scale. Our desire as civil society is that these processes be quicker. We appreciate that CAB took the least time to approval, but we hope the same happens for upcoming products, if not sooner. From a civil society lens, there are so many key issues for consideration as we think of implementation and scale up. And I will highlight these in the next. Not moving? Can you still hear me? Great.
We can, Imelda, and it did just advance. It may be slow on your side, but we're seeing the key considerations for scale-up.
Great. So for successful implementation and scale-up of injectable CAB and dapivirine ring, I have identified a few pillars for consideration. Firstly, this is the one that I wanted. There is leadership and commitment. We need our governments to be committed, accountable, and more efficient in how they approach implementation. Commitment includes expediting registrations and regularization of products that have been demonstrated to work. So we know, for example, in our region, we have governments that are not even considering the ring, and yet we know women want choice. We have governments that have not even started the registration process for CAB-LA in the ring, and yet we still have new infections each year. Then we look at financing. We need to continue to engage with PEPFAR, Global Fund, and other global donors. But more importantly, we need our governments to continue domestic resourcing towards procurement of these products. We also see an opportunity in the private sector where government could engage and advocate for public-private partnerships. Tied to financing is the cost of CAB, and I think Beatriz also talked about this, which currently is a critical piece that can be a barrier to access based on indicated cost for CAB-LA. We know there are several ongoing discussions around pricing of CAB, and we keep pushing VIV to make the product affordable for low-income countries while we await the generic manufacturing. While the cost for ring is lower, there is still a push for it to match current oral PrEP cost. On supply chain, we need the manufacturers to meet potential demand, but we currently don't have adequate injectable CAB, which will hinder scale-up. For current implementation studies, we're not sure if participants will have access to CAB post-studies, which is worrisome. However, we're happy that PEPFAR is committing to support CAB LA, but to what extent? Then when we look at ring, while we may have adequate ring supply for implementation studies, over time, these studies will inform actual demand. We are also excited that South Africa under Global Fund is committed to procuring ring for 2024. Again, kudos to civil society groups that push for this. We need more countries to follow suit. Overall, we advocate for cheaper generic formulations that can be produced regionally, but it seems far off into the future, especially for CAB. At the country level, we need commodities to be available, looking at the 6 Rs, the right product at the right place, in the right quantities, at the right time, at the right cost, with the right quality. However, we continue to hear of oral PrEP stockouts in healthcare facilities, yet product is often available at the central level. Bottlenecks to supply need to be identified to allow for access now more than ever as we lay on new PrEP products. For human resources, this is a huge issue as well, especially in our low-income countries where there's an acute shortage of healthcare providers. I think it's safe to say our healthcare providers are already overburdened, and this can compromise quality of care and service provision. So we need to tackle this from several angles. Train and retain healthcare providers. Again, this brings us back to commitment from our governments to appropriately incentivize healthcare providers. If scale-up is to work as we layer more prevention products, training is critical to build on healthcare providers' knowledge and competence in administering these new products, while allowing for choice counseling so that end users can comfortably choose what suits them best. How do we tackle provider attitudes that can potentially keep those at highest risk from accessing services or derail one product versus the other? As civil society, we strongly encourage our governments to seriously consider task shifting and identify cadres within the health system as well as communities like PrEP ambassadors or expert patients who can take on some of the responsibilities. Adherence is key if you want to see success on these products. Therefore, ensuring healthcare providers and communities have the right tools to encourage adherence becomes critical. For service delivery and design, this should be people-centered, and this is where differentiated service delivery models can come in. For scale-up of these new products, let's learn from ART, oral PrEP, and COVID, and identify what works. While injectable CAB may not work so well outside of the facility, ring has potential to be demedicalized, borrowing from DSD and possibly the community adherence refill group model or the vending machine system that South Africa has demonstrated. Overall, we just need to strengthen our health systems to accommodate new products while investing in community systems as well to also adopt new products. Are there opportunities for integration? Because we're often dealing with the same young woman who is on CAB and still needs contraception. And 9 months later, will need antenatal care, but she must go to many different units for these services. One other issue I want to highlight is drug resistance, which is a growing concern, especially for injectable CAB, and more importantly, insti resistance, especially in sub-Saharan Africa, where most first-line regimens include dolutegravir. Without robust follow-up, patients who are missing their visits, which is typical of our health system, drug resistance may increase, driving up HIV care costs. So how can we strengthen laboratory capabilities for monitoring patients on long-acting formulations? We need to invest in HIV testing algorithms that can detect incident HIV infections early. We need to consider the role of self-testing in the long run in the era of long-acting formulations. As we think about monitoring and evaluation, research and learning, we need systems to be able to monitor not just initiations, but also effective use. and data systems that generate quality data in real time. Again, oftentimes our systems are paper-based, resulting in data variances and errors, and where electronic health record systems are in place, it's not widely implemented. So if decisions are to be made, you want to make them on reliable data. Our call as civil society is for government buy-in and partner support so countries can have robust M&E systems. Last but certainly not the least, I think we currently grapple with, is how do you get healthy people to the clinic? How do we address end user concerns, perhaps stigma? What outward facing resources do we need to engage potential users with? What about adherence? How do we equip our healthcare providers for clinic-based adherence and strengthen our community interventions for adherence support? With drug resistance becoming a growing concern, we need robust adherence interventions for end users to stay on PrEP when at risk. Then in all of this, how do we ensure civil society, including communities, are front and center of all this? We insist that civil society and communities should be engaged in formulating and driving HIV programs. This hopefully will make end users feel that they are part of the programs and hopefully improve implementation success and help with reducing stigma and discrimination. So as I end this talk, key issues that we can take away. Choice matters. Let's make it work with current products while continuing to explore more options to widen our pool. We are looking forward to lenacapavir and the dual pill, hopefully in the near future, and vaccines and antibodies maybe later. Let's explore different routes of administration and formulations, modes of action and frequency. I truly believe that scale-up is feasible if we address the critical issues raised and make sure our services are people-centered and of high quality. As civil society, we need to continue data-driven advocacy and activism to ensure our systems are designed to deliver PrEP choices effectively and efficiently. Thank you.
Imelda, thank you. That was brilliant and a great compliment to Beatrice's presentation. This is just a superb set of presentations, and we have a tad less time than we had scheduled, but these are conversations that are going to continue for many periods, and really just want to thank you both. I know, Imelda, we can't see you because of some video bandwidth issues, but really am grateful to have your inputs. We have a bunch of great questions that have come in, and I'm going to take a couple in different orders, and hopefully I want to encourage people to continue to ask questions as we go. I think maybe we'll start, actually, Beatrice, with you. There are a couple of questions that I might bundle together about specific populations. And Imelda did a beautiful job talking specifically about how exciting it is for civil society that pregnant and lactating people are actually in some of the implementation studies. But a question came in about how to deal with CAB breakthrough during pregnancy and any considerations that you might want to make sure we are highlighting there. And I'll bundle it with the issue of clarifying a question about breakthrough infections for those who were actually taking CAB as expected. And again, we know it's not a perfect product, but clearly a question about whether you can give a little more insight into that. So maybe we'll start with those two for you.
Thank you. So regarding pregnancy, it is always more risky, the seroconversions that occur during pregnancy impacting the newborn, the fetus and the newborn. So clearly it's an increased risk. We also have the information from several regions that adherence is better during pregnancy and worse after the pregnancy. So I believe that I don't have a specific answer. I think we need to really work on preventively to not to have delays in the injections. For women, fortunately, we have a bit more forgiveness in the delays of the injections. So for men, we can't go more than 9-10 weeks maximum interval between injections. But for women, there is more forgiveness, and we can have 12. Not that we are changing at all the schedule of injections, but we need to know that there is a bit forgiveness there. So I think that adherence to the injection visits, we move from adherence to oral prep, and now we need to find a way to work on adherence to visits and injections. So it's also an important thing that we need to understand how best to do. So moving to the second question, would you mind about the infections during with injections in the right time, right? So it's important to note that in HPTN 083, among almost 3,000 people using CAB-LA, we had 6 of these infections, okay? And so we still don't know why these infections occurred. As such, we don't know how to prevent them to occur. So we don't see that the viral load monitoring during CAB-LA use would increase our capacity to really diagnose these infections. So we are still working to understand what is the pathogenesis behind these infections, and we are really dedicating a lot of time to better understand this. Still, we don't have an answer, but it's important to note that these are rare infections. In HPTN 084, we didn't have any of those.
Yeah, Beatriz, such great points. You know, there's still things we don't know about oral prep. We are learning, and I think we all need to go forward knowing that there are things we will continue to learn. And I really loved your point about adherence. And early on, people said, oh, cabotegravir, eliminates adherence. No, it's a different kind of adherence. Adhering to visits is different than adhering to a daily pill. It's not better or worse, it's just different. So I really want to appreciate you saying that. And maybe that relates to the question I'd love to give to you, Imelda. A great question came in about current awareness levels of cabotegravir being so low. And I think by extension, the knowledge of PrEP generally still remains very low. I wonder, you did mention it in one of your last slides about demand creation, but I wonder if you want to say a bit more about what, in a perfect world, what would you like to see as strategies for increasing awareness of PrEP as a category and the individual PrEP products? What should we be doing differently now?
That's a loaded question, but very important.
I'm giving you an unlimited budget, Imelda, so you can do anything you want.
Learning from PrEP, and I'll speak to the case of Zimbabwe. I think we realized a little later on that, we didn't do a great job in terms of demand generation, because at the time, I think we were worried to bring awareness too soon before product was actually available. And I think, we should be doing the opposite. I think we need for communities to start engaging with these products even before they are available. So you find that, under implementation science, for instance, where, Catalyst, where I'm working from, we are working closely with communities and engaging, civil society and communities to raise awareness within our communities around these products, so that they are aware that these products are whether in the pipeline during implementation studies. So, but by the time these products are on the market, people will readily access them. There are tools that we can use. I think there are tools, if you're looking at adolescent girls and young women, one of the things that they always complain about is we don't need too much information. It needs to be simplified. If it's materials that we're giving them, they need to be succinct, simplified in language that they understand. So, I mean, I could go on and talk about this, but there's so many ways we can approach this. All to say, it's important to raise awareness early. It's never too for people to know. Let's work with our civil society. Let's work with our advocates. Right now, we've got advocates that are pushing for introduction and scale up of these products within our communities, and that's just what we need.
Imelda, it was a beautiful answer, and it reminds me, early on in oral prep, there was fear that if we created too much demand, we wouldn't be able to meet the supply. And we need to flip that on its head, because if we don't build demand, no one's going to want these products and no one's going to need to make these products. And I think we've got to find that sweet spot, as you describe, of creating demand and not being afraid of creating demand, because if we don't, we will never build a market for prevention. So that is beautiful. I want to come back to you, Beatriz. One of the great things about 083 was how inclusive it was. And it was one of the first studies that actually really focused on getting the transgender community involved in the research with specific numbers. It wasn't an afterthought as it was in some of the early oral prep studies. We have a great question from someone on the line asking about the intersectionality for populations, both in the transgender community, also people who use drugs. And I wonder if you want to say a bit, as Imelda presented, there's no formal study looking at cabotegravir for people who use drugs. But I wonder if you want to talk at all about the intersectionality of these populations that often aren't included in our clinical trials or in small numbers, and how might we think about it, and what is CAB like for these populations, or what should it be like?
Thank you, Mitchell. This is a great question. So my understanding is that this intersectionality happened in 083. Of course, we had people using drugs. Injection drug use was an exclusion criterion. So injection drug users were not enrolled in the study. But we had drug use because it's really very frequent among these populations, young MSM, as MSM in general, mostly young MSM, and in transgender women, we found that they were using drugs, although we were not, we have no power to analyze how is the drug use related to the effectiveness of the strategy. So we don't have this specific data, but this population was included in 083, but not drug users, IV drug users. But I think this is a very important point, and further studies need to be done so that we can better assess this.
Great, Beatriz, thank you. A question, and this is a question I think that has been on everybody's tongue for a number of years now, the issue of cost effectiveness. Obviously a lot of data, and I wonder if either of you want to talk about expectations and targets for costing and cost effectiveness for cabotegravir and for the vaginal ring. Beatriz, I don't know if do you want to go first?
Yeah, as I shown the slide with the MPP agreement with VIV, as everyone is aware, and they will we will be able to purchase the generic form of cabotegravir for, we hope, a very possible price for countries to implement. Of course, it's difficult to think that it will be same price of TDF-FTC, but I don't have any information about the price. But unfortunately, this agreement doesn't cover many countries. And so in my country, Brazil, we are not part, we can't purchase generics, and we are in the hands of VIV to establish an agreement with our Ministry of Health. So we are in their hands, and the capacity from our government to negotiate these prices. But it's it's not a good position. Our country is not in a good position.
Great, thanks, Beatriz. Imelda, did you want to quickly add anything on that?
Sure. I guess, it's safe to say everyone wants the cost of CAB to be reduced, right? But I think it's not fair to expect it to be reduced to the same price as oral PrEP. I think I don't think that necessarily makes sense. But I do think we do need, quite a huge reduction for our governments to make an investment in this. I do think that, one of the things that Beatriz said earlier on in a presentation when the modeling was done, the benefits of investing in CAP, far outweighs, some of the cost issues that we talked about. And I think it's important for us to always look at that. If the modeling is showing that, there will be, she said 27% reduction, I think that's what she said, which is quite a dent, right? And I think, for me, those are things that, you have to weigh against, some of the cost issues. Granted, cost has to come down, but my issue is I don't think it will be fair to say that it should be the same price as oral PrEP, because it's just a different product. Yeah. And I hope I'm not making anyone mad.
No, I think it's a really important point. I know we're coming up to the top of the hour, but I think it's important that people also recognize that both the dapivirine vaginal ring and injectable cabotegravir are new novel products. When oral PrEP came to the market, we'd had decades of every generic company made oral TDF-FTC. And I think the task for all of us as a global community is to ensure that we are building a sustainable market for prevention and for all of the PrEP products, so that multiple manufacturers, and not just of oral PrEP as we have it in dapivirine ring and cabotegravir, but future products are able to be sustained. And that means we've got to build markets, we've got to build use. And as those demands go up, the price will come down. I actually think we'll get to a place where these products, if the market grows, will be similarly, if not the same, as oral PrEP, but we've got work to do, and there's a lot of momentum. Donors are stepping up, Global Fund and PEPFAR both, and again, we don't have time for that. We do need to draw this to a close. I know we have a couple of other questions, but maybe I'll give you each, if I may indulge the organizers, 30 seconds. Maybe I'll go backwards. Imelda, starting with you, any last thoughts? What you want the audience to leave this call with?
I think I said it before, choice matters. We have to
choice matters.
Yeah.
Beautiful. Beatriz.
Thank you so much. So I believe that we have good product, very good products, and we need to expand the use, starting from oral PrEP. But just building on what Imelda said, I think choice is critical, but it also depends on the prices that we get. Otherwise, we may not be able to offer it in a choice environment.
Yeah, no, it's a great point. And we want choices for individuals, but there are also choices governments make, policymakers make, health providers make, and that's the ecosystem that we're all engaged with. You both are fantastic, and these presentations, I believe the recording as well as the slides will be available on the IAS and HIVR4P website. When you signed up for this webinar, you will have seen a call on, I believe it's the 11th of October, just in a week, focused on vaccines. The week after that, on the 16th, focused on antibodies. The registration links are all there. We really encourage people to join those. And it's very important to remember that as we roll out the prevention products that we have, hopefully more quickly and more equitably, we also have a research and development agenda for next generation products, because no one product is going to help us end this epidemic. It's when we take all of these products together that we do that. So I want to thank Imelda and Beatriz both so very much. Thank the IAS Governing Council and the R4P Organizing Committee for making R4P space in 2023, and hope to see many of you on the webinars to come. And next October in Lima, Peru. Start thinking about what you want to be talking about then, and let's make sure those conversations happen. So thank you all so very much. Have great, safe days and nights, and we'll talk soon.
Thank you.